All right, so Dr. Dribin is with us today talking about anaphylaxis. His clinical specialty is pediatric emergency medicine. He was inspired to become a physician by his experiences with his childhood pediatrician and mentorship he received through his training. His research focuses on anaphylaxis. Dr. Dribin aims to improve anaphylaxis recognition and management in both emergency and community settings. His work includes studying the optimal observation period for biphasic reactions, identifying diagnostic and predictive biomarkers, and addressing barriers to best practices in care delivery. He is deeply grateful to the patients and families who participate in his research to improve outcomes for children at risk. Board certified in pediatrics since 2015 and in pediatric emergency medicine since 2019, Dr. Dribin has received multiple honors, including the Center for Clinical and Translational Science and Training KL2 Award in 2021, and the Pediatric Emergency Medicine Collaborative Research Committee Research Prize from the American Academy of Pediatrics in 2019. In 2024, he received a K-23 grant from the National Institute of Allergy and Infectious Diseases to develop personalized ED care strategies for anaphylaxis, and a Cincinnati Children's Place Outcome Research Award to create a smartphone app guiding families on epinephrine use in community settings. In 2023, Dr. Dribin co-chaired an international expert panel to develop a consensus definition, overview, and clinical support tool for anaphylaxis, including anaphylaxis criteria, epinephrine dosing, and a standardized approach for recognizing symptoms. So thank you for joining us. We will go through these learning objectives today, and I'll let Dr. Dribin take it away.
Great. Well, thank you very much for having me. It's a real honor. Can you see my first slide, Anaphylaxis Unveiled? Is that there?
Yes.
Great. Okay. And I am fine if people want to ask questions throughout, or if you want to wait. I recognize that if you move on from something and you're speaking about a new area, it can be a little hard to remember the question. So if someone wants to interrupt me, that I'm fine with that. Please, no hesitation. Again, thank you for letting me speak with you today. The talk today is Anaphylaxis Unveiled: Advancing Allergy Care with New Guidelines. Try to see, click through here. Okay, this is my research funding that's shown here. I have no conflicts of interest to report. And then the objectives of today's talk first are to understand the differences between the 2006, I'm going to call it NIAID FAN criteria, the 2020 World Allergy Organization criteria, and the new 2024 anaphylaxis clinical criteria. The second objective is to go into detail about these new 2024 anaphylaxis clinical support tool. It includes details about how to recognize anaphylaxis, the dosing and indications for administering epinephrine, and then common features and signs and symptoms that may occur with patients with anaphylaxis. And then the third objective is to recognize key facets of anaphylaxis management. This is a lot to talk about in one talk, so it's hopefully more high-level information. But if you have more questions, please feel free to ask me or email me, or I can meet with you offline. Just a little bit of epidemiology before we begin. We've done research showing that there are more and more emergency department visits for anaphylaxis in the US, and this is true globally as well. Data that we found from 2018 to 2016, there were over 400,000 visits for anaphylaxis in the US. And during this time, there was a threefold increase in pediatric visits and then a twofold increase in adult visits. Here at Cincinnati Children's, we see about 90,000 kids a year. In our emergency department, we have probably almost one visit a day. That tells you anything. So we see a lot of anaphylaxis. Fatalities, fortunately, are rare. Work that we've done showed that there was, as you can see, out of 42,000 encounters, there were 6 fatalities, and we just published a large multi-center study in the US, and there was 1 fatality out of 5,600 patients. So it's important to recognize that anaphylaxis definitely can be fatal, but it is uncommon for it to be fatal. However, the challenge with this is that for our patients and caregivers, it's almost impossible to predict fatality. The most common triggers for anaphylaxis are foods, medications, insect stings, and sometimes the trigger is unknown. Those are the hardest cases to try to figure out what's going on, especially in an acute care setting, inpatient setting, the emergency department, urgent care, primary care offices, where you're trying to figure out could this be anaphylaxis? The presentation of anaphylaxis, it is almost most patients, up to 90%, probably even a little bit more, have some skin or mucosal involvement. So they may have urticaria, whole body erythema, swelling of their lips, their tongue, their uvula. So it's a pretty good indicator that someone is probably having some allergic reaction or hypersensitivity reaction. It's almost always a multi-system reaction with anaphylaxis, but not always. The other organ systems that can be involved with the gastrointestinal tract, patients can have vomiting, abdominal pain, crampy abdominal pain, or diarrhea as well. And then the respiratory system is the other organ system. Patients can come in with upper airway obstructions from stridor. They can have respiratory distress, wheezing, bronchospasm, very similar to status asthmaticus, and then repetitive cough. It can happen quite a bit. And then cardiovascular is the other organ system that may occur, is definitely less common in young children than adolescents and adults, but hypotension, syncope, presyncope, dizziness, and the cardiovascular and the respiratory systems, if a patient is going to have a fatality from anaphylaxis, it will be from those organ systems. So they'll either have respiratory failure or they'll unfortunately have cardiovascular shock that is refractory to the treatments, or they are so sick that there's not even time to administer epinephrine. Those are rare cases, but unfortunately, the fatalities that we see are sometimes patients are so sick that they're not even able to make it into the emergency department because their presentation is so quick and severe. I do want to re-emphasize, and this is really important, that anaphylaxis is a clinical diagnosis, that there's no gold standard diagnostic test. So unlike trying to diagnose someone with diabetes or cancer or other conditions, it really relies on you or the person who is treating the patient to figure out, do I think they have anaphylaxis? There's no blood work that we can do to say, is it or is it not anaphylaxis? There's no strict criteria as well. So what we use, we don't have diagnostic criteria for anaphylaxis, we have clinical criteria. And the clinical criteria for anaphylaxis, they're intended to help people determine the likelihood that a patient is having anaphylaxis or is not having anaphylaxis. The difference is, compared to diagnostic criteria, for diagnostic criteria, if someone fulfills criteria, you say they have the disease or they have the condition. For clinical criteria, again, it's trying to say how likely, that there's no criteria that we have to say someone definitively is having anaphylaxis. I'd like to kind of think about this, that when I'm treating a patient, that there are patients that are very likely have anaphylaxis, where it's, no doubt. Someone eats a peanut and they're hypotensive and having respiratory distress. That's obvious anaphylaxis. Then there are the patients that are clearly not having anaphylaxis. But there's a lot in the middle where it's a little uncertain, and I think that's, imperative to reiterate that it's a challenging diagnosis to make. Sorry, these slides are like automatically jumping forward, so I'm having to go back and forth. One of the things that I like to impress upon individuals and clinicians is that anaphylaxis comes in a whole severity of how severe the reactions are. Anaphylaxis is the more severe spectrum of acute allergic reactions. And in 2021, we published a big consensus paper on trying to standardize how we grade reaction severity. And acute allergic reactions can occur from very mild reactions where they have isolated skin involvement, maybe someone has a little upset stomach, to those patients who have full-on respiratory failure and cardiovascular collapse. And I think what's important to recognize is that it's a severity spectrum, so that we're going to see patients all along the severity spectrum, from the grade 1 reactions that are the most mild to the grade 5 that are the most severe. And I think as clinicians and as researchers, we also want to put a horizontal line to say, if you're above this line, you have anaphylaxis, if you're below it, you don't. And I think that's always not as helpful to think about, that anaphylaxis is not as binary as we think it is, that there's a whole range of severity of patients with anaphylaxis, that you have patients with some mild anaphylactic reactions that actually self-resolve, to the ones that are full-blown, that they're not all the same severity. And this mirrors all conditions that we take care of, whether it's asthma, we see wide ranges of severity, cellulitis, pneumonia. It never has a uniform severity. So I just want to impress upon that sometimes it's not as important to figure out, is this anaphylaxis or not, but to really say, how sick are they, and do I or do I not think that the patient needs epinephrine? Now we're going to move on to the different clinical criteria for anaphylaxis and compare that to the new 2024 criteria. In 2006, the NIAID, so the National Institute of Allergy and Infectious Disease, and the Food Allergy and Anaphylaxis Network published these criteria. These were the first widely accepted, agreed upon criteria for trying to figure out, does someone have anaphylaxis or do they not? Before that, there had been variation in that. So this was a major advance, and my mentor, Hugh Sampson, was the first author on this. And he would say that it started in 2004 and it wasn't published until 2006. So there's a lot of contention and disagreement because, again, there's no gold standard way to diagnose it. The clinical criteria and the NIAID FAN criteria, there are three different criteria. And if you fulfill either one of the criteria, a patient is likely to have anaphylaxis. So the first criteria applies to patients without a known trigger. So this is someone that comes in, you're seeing them, there is no report of an insect sting, no report of a medication, no report of a food exposure. And you're trying to figure out, do they have anaphylaxis? So for this scenario, the author said that anaphylaxis is likely if it's an acute onset of an illness, you have skin mucosal involvement, so that's one organ system, and you have to have either respiratory involvement or cardiovascular involvement. And this is something that I try to impress upon my trainees, is that a lot of people think that if you have two organ system involvement, it's anaphylaxis, and that's not the case. If the trigger is unknown, people have skin involvement, hives, and vomiting. It can be from a viral illness. So it's not enough if the trigger is unknown just to have skin involvement and vomiting. You have to have skin, mucosal involvement, and either respiratory involvement or cardiovascular involvement. So in the case of the emergency department, if someone comes in, they have sudden onset of lip swelling and then they're wheezing, that person likely has anaphylaxis. If someone came in and they have, it's been 2 days of diarrhea and they have some hives, that's probably not anaphylaxis. It's probably more likely to be a viral illness. So that's really important. The second criteria is specific to when the trigger is likely. So if someone, was at a restaurant and they clearly were exposed to some food, they're maybe allergic to foods, or they have no prior diagnosis, but they ate a food and then they had a sudden onset of an illness. And this is when they would have to fulfill the criteria for likely having anaphylaxis. It's two or more organ systems. So this is the classic. You can have skin mucosal involvement, respiratory, cardiovascular, or persistent GI involvement. And any two of those, the person is likely to have anaphylaxis. Of note, a lot of people think that any gastrointestinal involvement constitutes someone likely having anaphylaxis, but the authors really made a note to say that it needs to be persistent GI involvement. So it's not enough for someone to throw up one time or say, hey, I'm a little nauseous. It needs to be ongoing GI involvement. Now, as in clinical care, it's really hard to define what is persistent, what is not. Is it a time duration? How long? So I think this is where it's up to the clinician treating the patient to define what they would think is persistent. But it's not just any GI involvement. And the last is the rare scenario where if someone's exposed to a known trigger, for example, a patient is peanut allergic, they eat a peanut, and all of a sudden they pass out and they're unconscious. They have no hives, they have no other symptoms. That would constitute anaphylaxis. And the reason for that is that if it's a known trigger, the pretest probability that someone's having that the symptoms that they're having is attributed to an allergic reaction is much higher. Versus if someone comes in the emergency department and they're hypotensive, it may be for many other reasons other than anaphylaxis. So that's why if they're exposed to a known trigger, the only organ system that can be in isolation in these criteria is to have isolated cardiovascular involvement. Same would be true if someone's in the operating room getting an anesthetic and all of a sudden they're hypotensive, and it's a known trigger that would constitute anaphylaxis. Or conversely, if someone's stung by an insect and they pass out, that would be likely to be anaphylaxis as well. These are the uncommon cases. So I don't think I've ever, sorry, it's jumping around here. I've never seen isolated cardiovascular involvement. It definitely can happen. Sometimes I think patients have isolated cardiovascular involvement and then develop other symptoms. So this is probably the one that's the least likely to be used, this criterion in clinical care. So now moving on to the 2020 World Allergy Organization criteria. The reason I'm doing this is to try to give you the background for what these 2024 criteria attempted to resolve. So the World Allergy Organization criteria, they switched it from 3 criteria to 2. And they did that because they wanted to make this simple, because they're like, oh my gosh, 3 criteria are so complicated. This is like overkill, right? Like, why is it this complicated? But in an attempt to make it simpler, it actually kind of lost some of the validity to it. So what they did is for that first criterion, they said this is specific to any trigger, including unknown triggers, that if you have any two organ system involved, if you have skin mucosal involvement and any of the three other organ systems, that you would likely have anaphylaxis. And if you remember from those NIAID fan criteria, the first criterion, if it's an unknown trigger, you had to have skin mucosal and either respiratory or cardiovascular involvement. This now says if you have hives, sudden onset hives, and you're vomiting and persistent vomiting, that you're likely to have anaphylaxis. And one of my good colleagues was a part of this, and he, I think, recognizes that that was an oversight, because in emergency departments or other places where the trigger is unknown, a lot of times those are not cases of anaphylaxis. So including the severe gastrointestinal involvement probably makes these criteria less specific, that you were probably labeling some things as anaphylaxis when they're really not. But that was the big change here, is that they got rid of it having to be a likely exposure to have gastrointestinal involvement. And for them, the other thing that they changed was in the they said for gastrointestinal involvement, instead of persistent, it had to be severe. This is how academics like to argue about the wording of persistent and severe. So while severe, I think, is maybe a little bit better, it says, it can't just be if you have persistent nausea, that by itself isn't necessarily severe. Again, it's up to the clinician to say how severe is someone's pain, right? Child's pain versus an adolescent versus an adult, it can be a little hard and very much open to interpretation. The
Can I ask
other
a question, Dr. Dribin?
Yeah.
So when we talk about severe, like with pain, we have a pain scale, etc. But when we talk about other, like in this case, severe gastrointestinal involvement, do we have any tools to assess the severity, or is it still kind of subjective?
I think it's other than the number of times someone vomits, right? Like if they keep vomiting, I think we would all say that. But there is not a validated tool with anaphylaxis to say how severe someone's pain is. Like if I had someone that's sitting there crying in discomfort, yeah, I'm gonna say that's pretty severe. If they're like running around the room and are like, I'm a little nauseous, like I'm gonna say probably not as severe. So, but I think you're gonna get definitely differences between clinicians, right? Between how I rate someone's discomfort and you. One of the big things is that a lot of the European allergists and Australian as well, they think when someone eats like a food that they're allergic to and they have vomiting, let's say, or upset stomach, they consider that a local reaction to the food, right? The food is in contact with the mucosal lining, and that's a local reaction, where there's definitely some data that, even with people, when they eat a food, it triggers a reaction in their intestinal system beyond the site of where that food was exposed. So it can be a more systemic process, but that's why there's a lot of disagreement about plenty of allergists that I know. They do not think, someone eats a peanut and they're vomiting and having hives. They don't think that's anaphylaxis. They think it's a local reaction. For them, if it's a food exposure, they really need to have more respiratory or cardiovascular involvement. So it's interesting how regionally people just look at this difference differently. And then the big change to the World Allergy Organization is as the prior criteria showed, that if you had isolated cardiovascular involvement after a known trigger, it's likely anaphylaxis. They introduced the concept that if you have isolated respiratory involvement after an exposure to a non-inhaled allergen, that would be likely anaphylaxis as well. What does that mean? That means that somebody eats a peanut and they all of a sudden start wheezing, and they're known to be peanut allergic. They wheeze. That patient is likely to have anaphylaxis, and you should treat them like you treat a patient with anaphylaxis with epi, and not treat them akin to how you would treat someone with an asthma exacerbation. Now, most of the time, if people are eating a peanut, they're going to get skin mucosal. So the chance that happens is unlikely, but their first symptom may be wheezing before they developed lip swelling or vomiting. So it's important to recognize for those patients to consider that anaphylaxis and to treat them appropriately. Now, if someone's like walking down a street and they're like roasting nuts and they're allergic to nuts and they start wheezing, and that's it, that would be an inhaled allergen. And if all they have is wheezing, then you would manage that akin to an asthma exacerbation. Similarly, if someone's stuck by an insect that they're allergic to and they have isolated wheezing or upper airway obstruction, that would be anaphylaxis, even if they have no other symptoms with it. Now, again, if someone's stung by an insect, they're probably going to have some skin findings, right, as well. But the important thing is that you can have isolated respiratory involvement. This slide just compares the two the two criteria, so the NIAID-FAN, the WOW criteria. In the US, the World Allergy Organization criteria have really not been accepted. So the NIAID-FAN ones are the ones that are still used predominantly. You can just see the difference here. The NIAID-FAN have 3 criteria, the WOW have 2. Gastrointestinal involvement is defined as persistent in the NIAID-FAN, severe in the World Allergy Organization. And then in the NIAID-FAN, it only includes isolated cardiovascular involvement. It doesn't include isolated respiratory involvement. So that brings us to a big paper that we just published in 2024 in the Journal of Allergy Clinical Immunology. This was led by Antonella Marraro, and then Hugh Sampson was the senior author, and he was the chair of the study. This was initiated by this organization, Galen, a European allergy organization, to really resolve the differences between these two criteria, because in clinical care, it's very confusing when some people are using the NIAID-FAN and others are using the WOW criteria. So for this study, we sought to develop a consensus anaphylaxis definition. So how do you define anaphylaxis? A clinical support tool that includes modified criteria for recognizing anaphylaxis, and then a summary document, an overview, which is really intended to be kind of the Cliff Notes version of anaphylaxis, that if you're trying to teach someone who's new to clinical care to say, hey, what is anaphylaxis? What causes it? How do you recognize it? How do you manage it? So the big kind of points there. We also included an international expert panel from around the world, and then medical and patient advocacy organizations. So medical organizations just to weigh in and provide feedback. So it was a lot to coordinate, and took about a year's time to do. These are the different experts that were involved. So emergency medicine, anesthesia. As you can see, most people were allergists, immunology, but we did have a public health person and a pulmonologist as well. So quite a bit of breadth. These are the different countries that were represented. So most were from the US, but you can see there were quite a few from like the UK and Spain as well, and Italy. These are the different medical organizations that participated, pediatric organizations, nursing organizations, intensive care organizations, the US Food, the FDA was involved, the NIH was involved with this, the European Medicines Agency. A lot of different people provided feedback about this, as you can imagine, some strong personalities. This is the definition that came from it, and this definition is a little longer than probably it would be if it was just for healthcare professionals, but it's intended to be applicable to healthcare professionals and also lay persons as well. The patient family organizations then provided input to make sure that the wording was clear. So the first sentence is probably the most important of the definition. It says anaphylaxis is a serious allergic or hypersensitivity reaction that can progress rapidly and may cause death. There was a lot of debate about whether we should include the wording of may cause death, and the patient advocacy organizations felt that was needed because there's still plenty of patients that don't recognize that anaphylaxis can be fatal, and there are still some healthcare professionals that don't think it may be fatal. However, we do recognize that it's a lot of medical definitions do not include may cause death, even though that they may. The second sentence then goes into the organ systems that may be involved, so the skin, mucosa, respiratory, cardiovascular, and gastrointestinal. And we included different descriptions of what those organ systems are, given that lay people may not understand, what cardiovascular means. And the last sentence is just to describe what are the signs of the most life-threatening reaction. So what is life-threatening anaphylaxis? And that's anaphylaxis characterized by respiratory or cardiovascular involvement, and it may occur without skin or mucosal involvement. I think this is helpful that, when we're seeing patients that never have respiratory or cardiovascular involvement, those patients uniformly do quite well. It's really trying to recognize who are the patients that are the sickest, who have the potential for adverse outcomes. And those are definitely the patients with, upper respiratory, lower respiratory, or those patients who are in shock. And those are the ones that we need to be mindful of. And then intentionally, we said that, these reactions can occur without skin mucosa involvement. I think a lot of people think that, if you don't have skin mucosal involvement, it can't be an allergic reaction. While that's true that most of the time people are going to have skin mucosal involvement, it's important that clinicians recognize that they may have a patient that does not have that, and that they need to make sure that they keep anaphylaxis on their differential and to manage it appropriately. The anaphylaxis overview, it's a one-page document. It goes through the definition, distinct findings in infants, which is unique. A lot of the literature on anaphylaxis is focused on adults. Children are hard, especially when they're nonverbal. They're young, they can be fussy because they're fussy, they haven't napped, that they're stressed about being somewhere, or they can be crying, pulling at their ears because they're having an allergic reaction. So it can be a little challenging in the young population to try to figure out, what are these, what are their findings? Is that specific to an allergic reaction, or is that just related to their stress and their young age? We go through what are the most common allergens. We wanted to, again, impress upon people that anaphylaxis does occur along a severity spectrum. So there's plenty of cases that are non-life-threatening. We go through the pathobiological description. So what's the most common causes of it from a more mechanistic standpoint? How to diagnose anaphylaxis, again, saying that it's a clinical diagnosis, that there's no biomarkers or diagnostic tests that you can do to help your decision making. And then we go through management, and I'm going to get through this management stuff later in the talk, so we'll go into some of that. Now I'm going to go through the 2024 support tool. So this is the clinical support tool, and this is probably the most impactful part of this paper. And the part of it at the top is important that this is only intended for healthcare professionals. It's not intended for lay people because there's so much on here that requires a lot of nuance to understand. And that a lot of lay people, it's just too complicated to understand what the different organ systems are, to integrate that and make decisions. So this is not used to inform when parents or caregivers should be using epinephrine in the community setting. That's a separate project that we have going. The clinical support tool is divided into 3 different components. There's the first part, which are the clinical criteria that look very similar to those NIAID-FAN, the World Allergy Organization criteria. The second part is indications and dosing for intramuscular epinephrine. And then the third part are common symptoms and signs for the different organ systems linked to the colors that we used in the clinical criteria. I'll now go through each component of the support tool. So the clinical criteria, as you can see, they look pretty similar to the Anaphylaxis, the 2006 criteria, and there are some changes. We did want to make this easier to use and interpret for people, that there was some way that the previous criteria had been designed that just make it a little hard for people that weren't familiar with it. Of note, we are developing a smartphone application for the clinical support tool so that anyone can bring it up on their phone and use it and not rely on a paper format. So again, these are not diagnostic criteria. And we say very clearly that anaphylaxis is likely. We don't say they do have it, or do not have it, but we say anaphylaxis is likely when any one of the following 3 criteria are fulfilled. So the first criterion is specific to when there's no known allergen exposure. So someone comes in, there's nothing possible that they were exposed to. They have to have skin mucosal involvement, and we made sure to highlight those in the same color because a lot of people treat skin and mucosal as separate organ systems, and that's not the case. So if someone has lip swelling and hives, that's one organ system. And that's why they're color-coded there the same. And for this, if there's no known exposure, they have to have respiratory involvement and either respiratory involvement or cardiovascular involvement. If it's a likely or known allergen exposure, they're likely to have anaphylaxis if they have 2 or more of the organ systems. So skin mucosal involvement, respiratory involvement, cardiovascular involvement, or severe gastrointestinal involvement. So instead of saying persistent, we said severe. And again, that is up to the treating clinician to make that interpretation about what they think is severe and what is not severe. And then similar to the World Allergy Organization, we said that if someone's exposed to a known allergen and they have isolated respiratory involvement after exposure to a non-inhaled allergen or cardiovascular involvement, they are likely to have anaphylaxis. So if any one of those 3 criteria are fulfilled, a patient's likely to have anaphylaxis. I would say the most common used in clinical care in the allergy clinic, everyone that they're giving, they're treating people or they're diagnosing them, they're giving them possible allergens. So for them, it's a likely or known allergen. So for them, they use that second or the third criterion. And I would say in the emergency department, we commonly use the second one too. But you have to account for the patient, that wasn't exposed to anything, and you're trying to figure out, is this anaphylaxis or is this something else? And sometimes it's unclear what the answer is.
How do you deal with comorbidity like asthma in this situation? How does this play into this?
Yeah, I think if they have a history of asthma, that doesn't mean that they're not having anaphylaxis. So I think it gets back to, were they exposed to something? So if someone with asthma was exposed, they ate a food and all of a sudden they're wheezing, we would say that would meet that, your likely allergy. Now, if they eat something they're known to be allergic to and they're wheezing, you would then want to say that that's likely anaphylaxis and treat them with adrenaline. If it's though someone, who's coming in, they just, were at their grandma's house or something or their friend's house and they're allergic to cats and they're wheezing, right? That is an inhaled allergen. So you would treat that like an asthma attack. So again, it gets back to what's the type of allergen? Is it a likely or known? And is it an inhaled allergen or is it not an inhaled allergen? What's hard though is sometimes you'll get people where it's, like they have a virus and they're wheezing from the virus and they have a few hives, right? And you're like, is this all viral or is this anaphylaxis? And sometimes you don't know. And I think I always impress upon people, if you're uncertain, you can give epi, right? And there's no downside. Epi works if it's asthma. It works if it's, asthma. It works if it's anaphylaxis, and it works if it's asthma. We use epi in asthma as well. The second component of the support tool is about clinical criteria, or is about dosing epinephrine. So this is specific just to intramuscular epinephrine or adrenaline, as it's called in some places. We wanted to make sure that people recognize that obviously you need to give epi immediately for suspected anaphylaxis. But one of the things that we had happened in clinical care is that people thought that if they did not fulfill the criteria for anaphylaxis, they shouldn't be giving epi. Like they had to fulfill criteria. And that was never the intent. We want the decision to use epi that it's independent of whether they fill criteria. That you can have a patient in front of you that you're unsure whether they have anaphylaxis or you think they just look ill and they don't fulfill criteria, but you still think like I need to give epi, and that should be supported. We want clinicians to make that determination. For example, if someone is known to have a serious life-threatening food allergy and they get exposed to something they're allergic to, and they all of a sudden come in and they have like whole body hives and they just don't look good. Even if their vitals are normal, even if they have no wheezing or vomiting or anything, it would still be prudent. A lot of people would still say, I'm going to give that person epi, right? They've almost died from this in the past. They have whole body hives and they look bad. That would be totally fine. That's different though. When we would look at that from a research standpoint, we wouldn't say that was anaphylaxis, but you could definitely say that that was appropriate to give epi, and I just want to encourage anyone on the call that if you think someone looks bad or you think they need epi, just give it, right? Independently of whether they fulfill these criteria. If they fulfill the criteria and you're like, hey, I think they have anaphylaxis, then definitely give epi. But we want to encourage patients that they can still give epi even if they don't fulfill criteria. We then included here the manual dosing for intramuscular epinephrine. So that's epi drawn up through a syringe. It's 0.01 mg per kg, the 1 mg per ml solution. This is, the different, it used to be 1 to 1,000, 1 to 10,000. It's now more the 1 mg to, ml. And that's the max single dose is 0.5 milligrams, is the max single dose. A lot of places only go up to 0.3 milligrams, but if you look, max single dose can go up to 0.5 milligrams. For auto injectors, there's one auto injector, the AviQ, that is a 0.1 milligram auto injectors. The other auto injectors are either a 0.15 milligram or a 0.3 milligram auto injector. In some parts of the world, they do have a 0.5 milligram auto injectors. We don't have them here in the US. Not many countries do. When to transition to the different auto injectors is a common theme. So I'll get patients that, they can't get the 0.1 milligram auto injector and it's a baby. Let's say they're 10 months old, right? And they're under 15 kilos. It's fine to give them the 0.15 milligram auto injector. Epi is incredibly well tolerated. Giving an auto injector is always better than not giving it. So we want to make sure that, if all you have is a 0.15 milligram auto injector and it's a baby, it's fine to give them that dose and not to worry about an overdose with a 0.15 milligram auto injector. We recommend, I think one thing that's important in the American Academy of Pediatrics calls us out too, is that, if you look at the manufacturer dosing, they say to transition to the 0.3 milligram auto injector when you're 30 kilograms or more. But if you do that, you're going to then be underdosing people who are, between, like a 28, 29 kilogram person. You're giving that person 0.15 milligrams of epi. So you're definitely giving them quite a bit under the 0.01 mg per kg. So that's why the American Academy of Pediatrics says to transition to the 0.3 milligram auto injector when you're 25 kilograms or more. So I think that's a really helpful thing as well. Actually, in Australia, the Australian Society, they recommend, they're even more bold. This is how safe epi is. They recommend transitioning when people are 20 kilograms to the 0.3 milligram autoinjector. So as you can see, autoinjectors are safe. I think that's the thing to impress. Giving an autoinjector is better than not giving it. In general, about 10% of people need 2 or more doses of autoinjectors. Most reactions, 90% respond to one dose of intramuscular epinephrine. The frequency is every 5 to 15 minutes, but if you have a patient who's looks like they're trying to die on you, you give them an autoinjector, they're stridulous, they're respiratory distress, they're like going in and out of consciousness. That would be someone I would not wait 5 minutes. You can liberalize the dosing and give it more frequently than that. So it's fine to do it more frequently than every 5 to 15 minutes. There's no absolute contraindications to autoinjectors. So we hear too, oh, people have heart disease, other stuff, right? I shouldn't give it. It's still well tolerated. And if someone has anaphylaxis, even if they have other comorbidities, to give epinephrine. The anaphylaxis organ systems are on the bottom. We link that to the colors used in the clinical criteria. So it is the skin mucosal is one section, the respiratory, cardiovascular, and gastrointestinal. We try to include the most common and serious findings, not the ones that are more kind of subjective. And then also interesting things that we did is we try to include findings that are a little bit more distinct to infants. So like for the mucosal section, infants may also have a repetitive lip licking, or for the respiratory symptoms, a sign of upper respiratory tract obstruction in an infant may be that their cry changes, that their tone of their cry is different than it normally is. As in an adult, our voices may change with that airway edema, but for infants, their cry may be different. So that is the 2024 anaphylaxis clinical support tool. It's been endorsed by over 30 organizations worldwide, including the American Academy of Pediatrics, the US allergy organizations, the college, the academy, the Canadian Society, the Australian Society. So I think going forward, our goal is that for these new clinical criteria to be what people use in clinical care, and developing the smartphone app will be free, and we're going to make sure that it's available to everyone, because part of getting this information out there is recognizing that most people do not read manuscripts and papers, that applications are what people use in clinical care or embedded in their EMR. So trying to get this information out there to improve the recognition and management of anaphylaxis. I'll try to fly through this part so to leave time for questions. So now I'm going to move on to management. Luckily, anaphylaxis management is not that complicated. I would say the one thing is, remove the trigger. So if someone's stung by something or bitten, you want to remove anything that's remaining. Proper positioning is key. The most important thing, though, is immediate intramuscular epinephrine and to repeat dosing, right? To get one dose in, and if they're not getting better, give a second dose, while activating, whether they're in a community setting, getting them, 911 call, getting them to a hospital, or in a hospital, just getting those doses in. You can keep giving intramuscular epinephrine over and over again if you don't have an IV, and that's fine. Obviously, if we're giving multiple doses and we have an IV, we like to start an infusion. But if you don't have that capability, you can keep jabbing someone in the leg. Now, it's not going to feel good, but it still will work. Upper airway obstruction makes me very nervous with anaphylaxis, because they usually have airway edema, and it makes for a challenging thing to manage. And then shock are the things that so upper airway obstruction, lower airway obstruction, so more of a status asthmaticus phenotype, and then the anaphylactic shock are the things that kill people. So it's trying to recognize those patients who are really, really sick and to intervene quickly. So positioning is really helpful. We always say, lie someone back and elevate their legs. And that is what you should do if someone's not having respiratory distress, which is, I think, something really helpful to think about. If you have someone who's in shock and they're not having breathing problems, you want to lie them flat and elevate their legs, right? And, give them epi, right away. If someone, though, is having respiratory distress, especially upper airway obstruction, if you lie someone flat, you could trigger them to go into the complete respiratory collapse. Because especially with upper airway obstruction, people like to sit in a tripod position where they're leaning forward, where their head's like this. And if you lie them flat, that will make their airway just collapse off. So if any time you see someone who's like, I'm having trouble breathing, or you think they're having trouble breathing, for that patient, you want to have them like sit upright and try to elevate their legs like on a chair or something. But you do not want to put them flat, because that is the worst thing that you can do for them. This is a reference from the Australian guidelines. So it has what to do if someone's pregnant. That's the second to the left. You lay them like on their lateral decubitus. If someone's having respiratory involvement, sit upright with their legs. What to do with a child. And then the thing you should never do is just, they shouldn't be standing up. So have them sit in a chair if they're having respiratory distress, or lie flat with their legs elevated, which is really key. Epinephrine, we talked about how frequently to give it. 10% of patients, I said, may need 2 or more doses to give it into the anterior lateral thigh. And again, you can give epi to patients who do not yet fulfill anaphylaxis criteria. And if I had an auto injector, and I'm not encouraging this, but if I had like a young kid who was really sick and all I had was like the 0.3 milligram auto injector, I would without a doubt give that. We give people all the time, sometimes 2, 3, 4 IM doses of epi, right? And if you think about that, if they're 0.15 milligram doses and you're giving 3, right, you're already at 0.45 milligrams of epi. So doing a 0.3 is not bad, like their hearts are healthy and can handle it. So it's better to err on doing that. There's a movement to actually do age-based dosing of epi and not weight-based dosing, because especially pre-hospital care, there can be a lot of errors with trying to calculate out the dose. So, the need to give exactly 0.01 milligrams per kilo, that was never studied scientifically in anaphylaxis. So it's a little bit of extrapolation. So it's sometimes easier just to say, if you're this age, you get 0.15. If you're this age, 0.3. And if you're this age, you get 0.5. Or sorry, 0.15, 0.3, and then 0.5. And not have to be giving these like 0.4 or 0.01. It gets complicated, and we know there's a lot of errors with epinephrine. We talked about the dosing and when to switch auto injectors. So when someone's 25 kilograms, to do the 0.3 milligram. Intravenous epinephrine, it should never be given as a bolus dose. That's associated with arrhythmias. If someone has had 2 doses of IM epi and they're still not responding, that's when I usually say, let's get an epinephrine infusion ready and start that. And what's nice is you can start at a low dose and then titrate to effect. And then you're not jabbing someone, it's not painful, and you can get it on and then titrate so they're getting a consistent infusion. But that should only be done by personnel who are trained. If you don't have that capability, again, you just keep doing the IM dosing until help arrives and you can get the patient to where they need to go. Just so people are aware that there's going to be non-injectable epi. It is FDA approved in 2014. It's called Neffy. It's a nasal epinephrine. There's a 2 milligram device for 66 pound patients who are 66 pounds or greater. And then Neffy 1 milligram was approved for kids who are 33 pounds to less than 66 pounds. They advise that if you give it in the nose, then if you're still having symptoms after 5 minutes, you need to do a second spray in the same nostril, which is, I think some people would want to do it at a different nostril, but it is to do it the same nostril. No, I just think it's really important. I don't have any I don't work for this company. I don't take any, so I'm not trying to advocate for it, but I just think it's the first non-injectable epinephrine device that's ever been out there, so it's important to talk about it. It was not approved based on data in patients with anaphylaxis. It was based on pharmacokinetic and pharmacodynamic data. So what were the levels of the drug? What effects did it have on heart rate, blood pressure, and healthy controls? And then they also looked at it with patients where they had a viral URI, and then they caused them to have an allergic rhinitis and tested it that way as well. So we don't actually have, there's some small little papers that are being published with like patients, like 15 patients or some very small sample sizes. We hope it works as well as intramuscular. We don't know though. And right now though, the FDA, the European, the EMA views it as equivalent to injectable epinephrine. So I think that's how it is. And there's plenty of families who are wanting it, but as healthcare professionals, a lot of people don't have experience with it yet. So it's hard for us to say, hey, how does this actually perform with the patient? And then we don't have the great clinical data yet to say, what about those really sick patients? Like, does this work well with someone who's in shock and respiratory sick? We don't know. And we may never know, because I don't know if there's going to be a randomized controlled trial. That would be the best thing to really say, how does this perform head to head with intramuscular? I do think, though, that we know that there's a lot of needle phobia, that adolescents, parents, they don't want to give a shot, right? We know that. So this is better than nothing, I always say. Like, I'd rather have someone get some epi than no epi, but I still think we're in the infancy of these devices. I think there are going to be more of them. And I think there's going to be questions about, how well do they perform, and hopefully we get more data on that. But I just wanted you to be cognizant of that we'll start to see these devices out there more and more. A little bit about upper airway obstruction. So again, ominous sign, someone can't breathe, they have airway edema. It's, you have to give IM epi. This is patients that we would consider putting on like a continuous infusion, because you want them, especially with kids, not to cry, because if they cry, get upset, it's going to make their upper airway collapse. So trying to minimize painful procedures. We'll sometimes give racemic or inhaled epinephrine. The teaching with this is you always want to intubate someone early, because their edema may swell, or their airway may get worse. So these are patients that if I have someone who comes in and they continue to have stridor, even if their SATs are good and they're stable, we would make the decision with anesthesia and ENT at the bedside to intubate them proactively. Because what you don't want to do is wait, the edema gets worse, and now you're trying to intubate someone who's hypoxic. That is the patient that will arrest on you during intubation. So you say, we're going to intubate them early in the course because we are concerned that they could get worse. And if we try to intubate them when they're worse, the outcome could be bad. So we give them plenty of pre-oxygenation. We have every team member there possible in case we would have to do a surgical airway. So that's scary. Oh boy. And then the other thing that, are scary is the patient's in shock. So anaphylaxis is a form of distributive shock akin to like septic shock. If you're having patients that, we don't put IVs in every patient with anaphylaxis. My adult colleagues still frequently do. But if I have a patient at all who has cardiovascular involvement, persistent respiratory involvement, or I'm needing 2 doses of epi, that they need IV access, and you should give them fluid, because they can lose a massive amount of fluid. So some of these patients may need 2-3 liters of fluid resuscitation. And then, like I said, start the epinephrine infusion. If you're needing a second dose of epi, to get that ready and to titrate it. Lastly, we like to give these patients antihistamines and steroids. There's never been an randomized trial of any anaphylaxis therapy, so no one really knows. I just want to be honest about that. The 2020 U.S. practice parameter said not to give steroids or antihistamines to prevent against biphasic reactions, but again, it's a very low certainty of evidence given all the data with this is it's non-randomized trial, so it's subject to a lot of bias. The big thing is it's fine to give antihistamine, Zyrtec, Benadryl, that stuff, even probably fine to give steroids. What we don't want is we don't want someone to ever give those medicines in replacement of giving epi, right? They should never be a substitute for epi. And I think that's the thing. Like if someone wants to give someone famotidine or prednisone, that's fine. But they shouldn't say, well, I'm going to do this, even though I know they need epi, but I don't really want to give them epi. Like that's where it's problematic. So I think that the decision is, do they need epi? Yes. And then to think thoughtfully about these other therapies. So if someone has upper airway obstruction, we're going to do racemic epi. And of course, we're probably going to give steroids, because steroids we use them in croup, upper, airway obstruction. Like it makes sense. Same if you have someone who has persistent wheezing and it's more of like an asthma phenotype, where they're eating a peanut and they're ongoing wheezing and vomiting. Like that'd be a patient, of course, who we give steroids, because we know they work in status asthmaticus. And then, I think the thing is with antihistamines, definitely like a second generation antihistamine. So is Zyrtec over at Benadryl. Zyrtec lasts longer than Benadryl, less sedating, and then there's been a randomized study in food challenges that the time of onset is actually just as quick as Benadryl. So it works as quick. So I think we always try to give Zyrtec over Benadryl. Benadryl's not wrong, but recurrent hives, persistent hives are what stress patients out, and getting something that's longer acting that's going to stay on board is a good thing. Again, when to give like H2 receptor antagonist, famotidine, no one knows. So what I'm saying, I don't know. I try not to get them unless it's someone who has maybe like bad vomiting that's not getting better, or if someone's like if I'm gonna have to intubate someone or they're in shock, yeah, I'm gonna give that because you kind of throw the whole kitchen sink at them at that point. So the evidence at that point goes out the window. But I almost never give H2 receptor antagonists for the run-of-the-mill anaphylaxis. And then I already talked about the antihistamines that really trying to do the second generation over the first generation is good. But if you only have Benadryl, that's fine. The last thing is kind of about how long we need to observe patients with anaphylaxis to monitor for recurrent or rebound reactions biphasic. Commonly, people will say 4 hours is what should be done. There's really was hardly any data supporting that 4-hour recommendation. Well, we now have data that's saying that we just published this past month that says that probably less than 4 hours is fine for patients who never have cardiovascular or involvement. So patients with just skin, mucosal, GI, or respiratory that gets better, they probably could go home safely around 2 hours. We did a big study with 5,600 patients across the US and Canada, and we used the timing of their initial epi to last those epi to figure out what their risk is. And what we found is that at 2 hours, beyond 2 hours, 4.7% of people get repeat epi. And then at 4 hours, only 1.9%. And this is for everyone in the cohort. So this is patients with cardiovascular, not. We then stratified it by organ system. And for those patients with just who never had cardiovascular or respiratory, it's like it goes down to like an hour, hour and a half is probably fine. So it's something that I think how long we need to watch people needs to depend on how sick the patient is in front of us. Usually we say hospitalization criteria to bring people into the hospital, they need 3 or more epi doses. If they have refractory anaphylaxis, again, 3 or more epi, they're not getting better. And then I never send someone home who has persistent respiratory or GI findings. Like if they're still wheezing, I'm not going to send someone home with that. We send wheezers home all the time who have asthma. That their wheezing is not going to stop. But someone with anaphylaxis shouldn't keep wheezing. Like you shouldn't send them home. Same, they shouldn't be vomiting still or have bad belly pain. So they can be sent home with still having hives, right? Hives can stick around for days, come and go. That's all right. Same with a little lip swelling, but any GI findings or respiratory stuff or obviously cardiovascular, they would need to, if it's persistent, come into the hospital. Discharging patients, we always say counsel them on avoiding the allergen, make sure they have an epinephrine delivery device, either in hand or prescription, to have an anaphylaxis management plan that is reviewed with them to go over indications for when to use epi, make sure that they're aware of that. And then if they don't already have an allergist, to have an allergist that they can follow up with to try to figure out what their triggers are, any other triggers that they need to be aware of. And then allergists can sometimes do some like oral immunotherapy or other things to decrease sensitivity. And that is the talk. So we've reviewed the anaphylaxis clinical diagnosis, the new 2024 criteria, take-home point, give epi, timely epinephrine, and that you can give epi even if people don't fulfill anaphylaxis criteria, that's fine. A little bit about those scary things that make us all sweat, so upper airway obstruction and shock, and then what are the cornerstones of safe discharge management. So that is the talk. I'd open up for questions.
Thank you so much. I'll let Lindsay just say what she has to say about this activity today.
Yeah, I did put in the chat that this activity is approved for 1 contact hour from the AANP. And then you'll find a link to go ahead and access your CE credit. And then members will also receive an email with that same link and recording. All right. And then I think there was a couple questions in the chat I will read. And then if we can open it up to any other questions. One is, when will the app be available?
The app is being developed by FAIR, which is the Food Allergy Research and Education. It's a large nonprofit. We've actually just set up the contract with them, and then we have the app builder. So I would hope in the next like 6 months it will be built. And then we can work with your organization. We really want to spread the word that this is going to be open access, free, because we want to get this into as many healthcare professionals' hands as possible, just to get it out there and just spread the correct information. So we'll be in touch when that's developed. Yeah, and we'd love feedback too from like anyone who wants to test it, because we want when it's out there to make sure that when people are using it, that it answers their question and it isn't confusing, right? If someone uses an app and they think it's clunky or confusing, the language is bad, they're not going to use it again. So we're really going to do a lot of pilot testing before going live with it.
That'd be great. Actually, we do have a couple of our members on the committee with FAIR on the education committee, but we do work with them as well. So anything you need help with, we'll be happy to contribute from the nurse's perspective. And we talked about this at the anaphylaxis meeting in the Quad AI last time. Is that at Quad AI we also developed an anaphylaxis learning guide, and that interactive learning guide, which I put a link in the chat to for those who might not be familiar, and that's primarily for the patient use, unlike what this new app sounds like is going to be mostly for healthcare professionals, or is this, yeah?
Yeah, it's going to be for healthcare professionals, and then we're working with AFA, the Asthma and Allergy Foundation of America. We've been doing for the past 2 years an international study to develop a smartphone app for patients and caregivers to impute what symptoms they're having and then get recommendations around giving epi. That app, though, is going to not be focused on is this anaphylaxis, which is for most lay people, they don't care about is it anaphylaxis. They just want to know, do I need to give epi or not, right? That's what's important to them. So we're trying to make it very patient-centric, so it's easy to use and that people get timely recommendations about giving epinephrine to hopefully overcome some of the hesitancy that users can have where we get a lot of people are like, I know I should have given epi, but I didn't. We want something to say, hey, you should be giving epi for this reason, and to optimize epinephrine use.
I have some hands up, Mary and then Josie.
Marion, go ahead. Okay, she's not speaking, so I will. Thank you very much. This was an excellent talk, really outstanding. And the way you differentiate between the clinical diagnosis and the independent need to, administer epi if the patient's not feeling well, et cetera, is really well done. I did have a question about the 0.5 versus the 0.3, and you did touch on this. Are we underdosing adult patients by using the 0.3 milligrams in the US, or is that not a concern from your standpoint?
I do want to be totally transparent. Like the more I study anaphylaxis, the more I realize we don't know. So the whole 0.01 mg per kg has never been studied in anaphylaxis. Like no one ever did a study be like, let's do 0.01 versus 0.05, or let's do this max 0.3 versus 0.5, right? I think the thing that I would say is that like in our ED, we almost always just do 0.3, even if we have like an 80 kilo person, right? The thing is 0.3 works most of the time. So people are like, hey, like why would we do 0.5? I think it's fine to do 0.3, just knowing that, look, if you have someone who weighs like 80, 100 kilos, you may just need to do two IM doses that then 0.6, right? So you're basically giving an adult dose. I think though, it's also just want to make sure that if people want to go to a 0.5 max, that is perfectly correct to do that. Like to say, we're going to max out at 0.5. I think there's potential that we're underdosing adults. But again, I think in most healthcare facilities, if someone's not getting better, they're going to be like, just give another dose real quickly. So that's my nuance to your answer. But I do think we should encourage people on their medication list in the hospital that it would be fine to go up to 0.5 if they're 50 kilograms or more.
Okay, I appreciate that nuanced response, and
Yeah.
I think you're right on the money. And then you seem to be a little bit more forgiving of Benadryl per se than I think a lot of what I read. So it's still okay for. I think the second generations are getting a big push, to step away from Benadryl. What are your thoughts on that?
I think if you have a second generation versus a first generation, I would always give the second generation, right? Like it's going to make people less tired. It will last longer. Time to onset is the same, which is good. Skin mucosal stuff is what stresses people out, right? Their hives come back, their angioedema. If though you get Benadryl, I think we need to make sure people are like, giving Benadryl for hives is not wrong, right? No one's doing something like it's not malpractice here. I just think if you have the option, you should select probably the better medication. The other thing is people like if someone comes in and they got some Benadryl at home, I'll still give them Zyrtec in the ED if they still have hives, right? Our allergists, they really hit them with high doses of anti-hit. They'll like double or triple their like Zyrtec dose. And I'm not endorsing that, right? Because they're experts in that. But most antihistamines, you can get a lot of it and not have anticholinergic symptoms, if that makes sense.
Thank you very much. Appreciate it.
Yep.
We have some more questions, I think, Lindsay.
Yeah, it looks like Mary, would you like to try again? If not, I can read the question from the chat.
Yeah, we cannot hear her. I think she's trying to
Okay.
speak.
I'll go ahead and ask hers. So she said she's willing to work with Dr. Dribin for his pilot to app. Her students would be, perhaps could educate community, non-medical. Also, can you incorporate the tool into an Epic system similar to the septic bundle or Muse scoring inpatient?
I think that would be great. I think like I'm not an informatics person, but what I've realized is that every institution there, there's Epic and then there's Epic, right? And Epic can be and how, it's not trivial for each institution to build their own basically clinical support tool into Epic, right? Where it walks you through that. So I think it'd be great if your hospital has that capability to where it could, you could click on something, it could walk you through. We're also trying to work with MD Calc. I don't know if you all use their resources, but they're an online free website, and they have a lot of where they basically take published algorithms, clinical support stuff, and then have it on a clickable thing. You can have it on your phone too, where you walk through and you say, is this present, yes or no? And then it says basically, is a diagnosis likely or not, and to link it to the treatment. So we're trying to work with them because I think it'd be helpful for them to include the clinical support tool on there as well for people to pull that up and be able to walk through it if they don't have the app.